Good evening, everyone, and welcome to the fifth session of JIPMA's Target Volume Delineation webinar series. Today, we are joined by Dr. Syed Tausif. Dr. Tausif has been an SR in JIPMA till recently and is now practicing as a consultant in Care Hospitals, Hyderabad. As a member of the JIPMA team, he has been a go-to for us for our head and neck target volume delineation throughout his course over here. And he has demonstrated extensive knowledge and expertise in head and neck conformal radiotherapy and associated target volume delineation. He has been a go-to for all of our JRs over here whenever they want to learn anything about target volume delineation in any site be it. But he has had special expertise and interest in head and neck oncology. So, Dr. Tausif, if you are ready with your presentation, I think we can start.
Yeah, sure. Thank you for the warm welcome. Yeah, is my screen visible?
Yeah, it's visible.
Yeah, okay. So we'll start. Good afternoon, good evening, everyone. So today we'll be discussing on cervical lymph node delineation. So the following will be the outline of my presentation today. So first we will have an introduction of the cervical nodal classifications, how these nodes have been classified and how they've evolved over time. Then we go to vessel anatomy. We've already released a module on vessel anatomy. However, I'm not sure how many of you have attended that. So we'll quickly brush through vessel anatomy because that knowledge is very important to understand nodal level contouring. Then we go on to cervical nodal levels. I'll go slightly unconventional and change the sequence of how we're going to see them. So we'll start off with level 2, 7B, and then go to level 3 and level 4A and 4B. These are the lateral nodes. Then we move on posterior to the level 5. And then we cover 7A and then move on to the anterior group of lymph nodes. If you remember it this way, I think it's easier to remember all the nodal levels. And then each level, when we describe, we'll see general information about them. We'll see the anatomical boundaries, then we see target volumes, and then we see how and when we have to treat them. So coming to the introduction, how and when these nodal levels have evolved, how these numbers and these nodal nomenclature have come into picture. So until the 1990s, there was no standard nomenclature for nodal levels or for neck nodal dissections. So for the first time in 1991, the American Academy of Otolaryngology Head and Neck Surgery group, headed by Dr. Thomas Robin, they gave the first classification of neck nodal levels. So in that they described 6 nodal levels and they've numbered them from 1 to 6. There was a few nomenclature before that, but it was not organized and they never had numbers before these. So they had level 1 to 6. And they have described lymph nodal levels such as the submental and the submandibular, the upper, middle, and the lower jugular, and the posterior triangle group. So 10 years later, they gave a neck dissection classification update. Since the first paper that they had released was mainly for surgeons, so it was surgical landmarks and all the levels were mainly for surgery. So they gave a update 10 years later, in which they did 2 things mainly. The first thing is they divided certain neck levels into 2 because they have certain biological significant biological implications. So they divided certain levels into 2. We will see that in more details. And they also used radiological landmarks as surrogates to surgical landmarks. This would facilitate in radiology and also in target volume delineation. So they gave radiological landmarks to their surgical or anatomical landmarks. So this was the surgeons. So all of this was mainly intended for surgeons. So the first paper for radiation oncology for target volume delineation came by the group by Vincent Gregoire. This was the Brussels guideline. This came way back in 2000. There was another guideline called the Notre Dame guideline, which came approximately the same time. Then there was understanding of the fact that there was need for a consensus guideline from major cooperative groups across Europe and North America. So this consensus guideline came out in 2003. That was pretty much standard till 2013 for 10 years, where the same group gave an update of their current consensus guideline. And this guideline is what we follow up to date. There's no update after this. And this is what will be the core for most of our presentation today. So this is what this is the final levels that have been described in this consensus guideline. So they've added a few more lymph nodal levels, and we'll see how and why they are important. So to start off with, level 1 is 1A and 1B, submental and submandibular group. Level 2, 3, and 4 are your lateral group of lymph nodes. So the upper jugular, the middle jugular, and the lower jugular. In the level 4, you have level 4A and level 4B. So level 4B is basically the medial supraclavicular group. Then comes level 5, which is the posterior triangle group, in which you have 5A, 5B, and 5C. Then comes level 6, which has 6A, which is anterior jugular, and 6B, which is prelaryngeal, pretracheal, and paratracheal group of lymph nodes. Level 7 has retropharyngeal, level 7A, and retrostyloid is level 7B. Then you have parotid group, buccofacial group, and posterior skull group as 8, 9, and 10 respectively. So we'll see them in more detail. So like I mentioned, we'll first start off with vessel anatomy. Okay, so this is the arch of the aorta. So the arch of the aorta gives three main branches. The first one is the brachiocephalic trunk, then comes the left common carotid, then comes the left subclavian. So the brachiocephalic trunk further divides into a right common carotid and a right subclavian artery. Coming to the IGV comes down. The right IGV fuses with the right brachiocephalic vein and forms the with the subclavian vein and forms the right brachiocephalic vein. There's another brachiocephalic vein that comes from the left side. Both brachiocephalic vein fuse and form the superior vena cava, which opens into the right atrium. Okay, so we'll see how it looks on a CT scan because that's what we are interested in. So we'll start off from the atrium and we'll track the aorta. So this here you can see the ascending aorta. So this here is the ascending aorta. So I'm scrolling caudal to cranial. So you can see the ascending aorta, and now it will continue as the arch of the aorta. So this here is the arch of the aorta. So it's very important to identify it. So you can go to the left ventricle, see the ascending aorta come out of it, and then see the arch of the aorta. So this here is the arch of the aorta. So we saw that the arch of the aorta gives three branches. So these are the three branches of the arch of the aorta, 1, 2, and 3. So this here is the brachiocephalic trunk. This here is the left common carotid, and this here is the left subclavian. So for now, I'll just follow the brachiocephalic trunk. So the brachiocephalic trunk will further divide into a right common carotid and a right subclavian. So this here is the right common carotid, and this here is the right subclavian. So the right subclavian moves into the upper limb and continues as the axillary vessel artery and common carotid. So we'll track on common carotid artery now. We'll come back to IGV in a while. So this is how common carotid moves in the neck. It ascends all the way through the neck. So this is how you typically see them. So the common carotid and the internal jugular vein. So the common carotid artery is more circular and diameter wise it's slightly smaller than the internal jugular vein, and it lies medial to the internal jugular vein. So both of them ascend throughout the neck close to each other in the carotid sheath. So here you can't see the carotid sheath. In the carotid sheath, we have the vagus nerve, the common carotid artery, and the internal jugular vein, which are going throughout the neck. So it's very important to identify these structures, because if you don't identify them, then you won't know when you see an abnormal node or some other vessel. So it's very important at this level you don't have anything else to confuse it with. If you have a node negative neck, you will only see the common carotid and the internal jugular vein here and nothing else. This here, as I know, we can only see two vessels over here. I see something over here and I know that's a node. So always, whenever you want to identify the common carotid, you will see as you go cranially, it becomes a little difficult. There are a lot of structures, intricate structures over there. So it's always a good idea to scroll all the way in the neck over here at this level and trace the vessels from here. So we're going to continue to track common carotid artery. So this here is the common carotid, lateral to which is the internal jugular vein. So at approximately the level of the C3 or the C4 vertebra, the common carotid artery divides into the external carotid and the internal carotid. So this here is the internal carotid and this here is the external carotid artery. So the internal carotid artery continues to ascend inside the carotid sheath along with the internal jugular vein and the vagus nerve. However, the external carotid artery exits the carotid sheath. So we'll continue to now see the internal carotid artery again. So this here is the internal carotid artery, again continuing to lie medial to the internal jugular vein. So you can see this, it continues to go. So like I mentioned, at this level, it might be a little difficult to identify the internal carotid artery just based on this simple cut, because you have a lot of branches, a lot of muscles, intensity wise, they're more or less similar. So it's always a good idea to scroll down, identify the common carotid, and then come up, see the bifurcation, and then track the internal carotid artery. So I'm continuing to track the internal carotid artery. So it goes into the carotid and enters the brain. Okay, so now we'll track the internal jugular vein down. So internal jugular vein continues from the sigmoid sinus. So this here is the internal jugular vein coming out through the through the jugular foramen. So this here is the internal jugular vein that continues to lie lateral to the carotid artery. So internal jugular vein and the internal carotid artery. So now this is below the bifurcation. So now you see the common carotid artery. So it's very easy to identify these two vessels, and it's very important to identify these two vessels, as we will see in our contours eventually, that these two are very important for target volume delineation. As I mentioned, the right internal jugular vein will fuse with the right subclavian vein. The subclavian vein has come from this side and joined the right internal jugular vein, and now they form the right brachiocephalic vein. So the left brachiocephalic vein will cross to the right and fuse with the right brachiocephalic vein and form the superior vena cava, which opens into the right atrium. So I hope visual anatomy is clear. If there is any disturbance in the video or the voice, please interrupt me.
No, it's going fine till now. There's no disturbance.
Yeah. So thank you. Okay, so now that we have done vessel anatomy, so we'll proceed. Okay, so we'll start off with level 2, like I mentioned. So level 2 is probably the most important nodal level. Whenever you're contouring electively or for a node, whenever you contour a neck, you will almost always invariably contour the level 2 node. So it's very important. Level 2 and level 3, you will almost always contour in every patient if you're treating the neck. So level 2, as defined by Thomas Robbins in 1991, the first paper that started definitions for nodal levels, they called level 2 as the upper jugular nodes, and this terminology is still retained. So level 2 is lymph nodes located around the upper third of the internal jugular vein and the adjacent spinal accessory nerve, and extending from cranially from the base of the skull caudally up to the bifurcation of the common carotid artery or the hyoid bone, which can be used as a surrogate for the bifurcation of the carotid artery. The posterior boundary is again the posterior border of sternocleidomastoid, and the anterior boundary is the lateral border of the sternohyoid muscle. So basically, this is how it is. So all the way from the base of the skull till the bifurcation of the common carotid artery, posteriorly limited by the posterior border of the sternocleidomastoid, is your level 2. So the classification update that came 10 years later, and this they have further divided level 2 into level 2A and 2B. This is because they saw clinical significance to it. So tumors of the oropharynx and the nasopharynx, please remember this, tumors of the oropharynx and nasopharynx have a tendency to spread to level 2B. They have a tendency to go to level posterior node, so the level 2B. So 2A and 2B was basically divided by the spinal accessory nerve, which is obviously not visible on a CT scan. So a surrogate for that is the lateral border of the internal jugular vein. So posterior to the internal jugular vein is your level 2B, and anterior to your internal jugular vein posterior border is your 2A. So basically internal jugular vein is part of the 2A. So in your 2B, usually you have nodes coming from oropharynx and nasopharynx, whereas level 2A, you have nodes mostly coming from oral cavity and larynx and also hypopharynx. So oral cavity, larynx and hypopharynx, like I mentioned, usually go to 2A. They don't usually go to 2B unless 2A is involved. So the implication of this subdivision was that if you do have a patient of oral cavity or larynx who doesn't have a 2A node, then it's immaterial to do a surgery for 2B, because the surgery for 2B comes at the cost of a morbidity of injuring the spinal accessory nerve. However, till recently, we'll again see it in more detail. Till recently, in the radiation oncology committee, we did not know what is the implication of this division between 2A and 2B. Since we are not operating, so we don't know whether saving 2B really matters. Does it cause any additional morbidity in terms of nerve damage? So for radiation oncology perspective point of view, until recently, we used to treat level 2 as a whole. But for surgeons, they usually divide 2A and 2B. So the same classification, so the same group, they used radiological landmarks for level 2B. So sorry, for level 2. So 2A was superior border skull base, inferior border hyoid bone, inferior border for both 2A and 2B. Anteriorly, like I said, 2A extends from the stylohyoid muscle till the vertical plane defined by the spinal accessory nerve. We know the surrogate for this is the posterior border of internal jugular vein. And posterior to the internal jugular vein up to the posterior border of sternocleidomastoid is your 2B. So this is our delineation guideline. So this is what we are following now. So level 2 or the upper jugular group cranially starts at the caudal edge of the lateral process of the C1. So if you notice, till now we were seeing the cranial border as the base of the skull. And now we see it's the caudal edge of the lateral process of the C1. We'll see the reason for this. Just keep this in mind. Caudally, it extends up to the caudal edge of the body of the hyoid bone, which is a surrogate for the common carotid artery bifurcation. Anteriorly, it extends up to the posterior edge of the submandibular gland, because there it is continuous with the level 1B, the submandibular group of lymph nodes. Or where you don't have the submandibular node, it's restricted by the posterior belly of digastric. Posteriorly, it is restricted by the posterior edge of the sternocleidomastoid. Please keep in mind, all across till we study level 2, 3, and 4, posteriorly it will be restricted by the posterior edge of the sternocleidomastoid, and lateral boundary will always be the lateral border of the sternocleidomastoid. So that's why I put them together, level 2, level 3, and level 4. Laterally, it is again limited by the deep surface of the sternocleidomastoid, and where you don't have the sternocleidomastoid, the platysma or the parotid or the digastric. And medially, medially, you have to include the internal carotid artery in your contour. So level 2 contains upper jugular group of lymph nodes located around the upper 1/3 of the internal jugular vein and the spinal accessory nerve. This lies deep to the sternocleidomastoid and includes the internal carotid artery and the jugular vein. So as already discussed, level 2 can be further divided into level 2A and 2B by the posterior edge of the internal jugular vein. And the usefulness of this distinction between the two sublevels is a matter of discussion in the radiotherapy community, as we have already discussed. So this here is your level 2, all the way from the transverse process of the first cervical vertebra to the carotid bifurcation or the hyoid bone, and divided into 2A and 2B by the internal jugular vein. So we'll also see level 7B. Level 7B is nothing but the cranial continuation of your level 2. So as I mentioned in the 2013 update of the contouring guidelines, level 2 lower border was reduced. Level 2 upper border was reduced from the base of the skull to the transverse process of the first cervical vertebra. So this space between the base of the skull and the transverse process of the first cervical vertebra was given a new name and a new number, which is the level 7B or the retrostyloid. So it is very, very simple. Just the cranial continuation of level 2 beyond your first cervical vertebra is nothing but your retrostyloid group of lymph nodes, or the level 7B. So it was obviously not described in your surgical guidelines. It was only described in this 2013 update, where they proposed it as a new nodal level. And the implication was this, is that it is rare to have a node in the level 7B unless you have bulky involvement of level 2. So unless you have a level 2 node, you don't have to treat all the way up to the base of the skull. You can restrict yourself till the first cervical vertebra transverse border. So I will see how it looks on the contour. We'll first see the boundaries. I'll first go to level 2 and then come to 7B. So this is the level 2. So over here, you can see this is the transverse process. This is the first cervical vertebra. This is the odontoid of the C2. So this is the transverse process of the first cervical vertebra. Now I'm going to scroll caudally. So as I go down, the transverse process of the first cervical vertebra ends over here. So there are no targets in this. This is only boundaries. So just to show you how the anatomy looks. So here your level 2 contouring will start. So I'll scroll down a little lower. The anatomy is much more clear. Okay, at this level. So your level 2 is nothing but this space, this fibrofatty space that is between the sternocleidomastoid laterally and the paravertebral muscles medially. So this space, this very thin space posteriorly. So this entire space is your level 2 or your upper jugular group of lymph nodes. And also, obviously, like I already mentioned, you will always have to include the jugular and the common carotid artery or the internal carotid artery, based on what level you are at, into your contour. So your contour would come like this. Over here restricted by laterally by the sternocleidomastoid, here laterally restricted by the parotid, here restricted by the posterior belly of the digastric, include the jugular, include the carotid, and then come back here. Always remember, in this case, like we're including vessels because their lymphatic channels flow along with the blood vessels, so we are including them. But all other normal structures, such as the muscle, the bone, the parotid, I mean all the other normal structures have to be excluded from your contours. You only have to include the fibrofatty tissue that can harbor nodes and lymphatic channels. So never include your normal structures. When you're contouring here, please don't go into the parotid, don't contour over the digastric, because these are your normal structures. These are barriers to spread of disease, and you won't have disease over them unless they are breached, of course. So as you can see over here, so this space laterally by the sternocleidomastoid by the parotid at this level, anteriorly by the submandibular gland, and over here by the posterior belly of the digastric, medially to include the vessels, both the internal carotid and the jugular vein, and then laterally, medially exclude the paravertebral muscle. Posteriorly will be by the posterior border of the sternocleidomastoid. So this is your level 2. So at this level, what happens is you don't have the parotid anymore. So beyond the sternocleidomastoid, since anteriorly I'm going to go up all the way up to the submandibular gland here and include the vessels over here. So in this level, you don't have any barrier. So you have to include level 2 all the way up to the platysma at this level. So you will go like this. We'll see the volumes in a while. This is just to show you the normal anatomy. So this is how the contour would look over here. At the caudal edge of the hyoid, our level 2 contour will end. So I'll again go to level 2 first. So at the caudal edge of the transverse process of the first cervical vertebra, your level 7B becomes your level 2. So this is your level 2. I've included the internal carotid artery and the internal jugular vein into the contour. As I go down, you can see the posterior belly of the digastric. I'm literally limiting myself to the posterior belly of digastric. Over here, I'm including the space between the paravertebral muscles and the sternocleidomastoid. Laterally, over here by the sternocleidomastoid. Over here by the posterior belly of the digastric, including the vessels. And again, coming medially, restricting by the paravertebral muscles. So as you go down, the space becomes much more prominent. So at this level, for example, laterally restricted by the sternocleidomastoid. Over here, you don't have the sternocleidomastoid, so you go all the way up to the platysma. Over here, you don't include the parotid or the submandibular gland. This is the submandibular gland that forms the anterior boundary of level 2, because anterior to this will be your level 1B. Then you medially exclude your bone, include the vessels, include the internal carotid artery, and then come back posteriorly. So again, laterally sternocleidomastoid, over here the platysma, anteriorly submandibular gland, medially exclude the normal structures, include the carotid, and medially stay out of the paravertebral muscles. Okay, so level 2 over here at this level at the caudal edge of the hyoid bone continues as level 3. So we'll go back to 7B now. So I'm going from caudal to cranial, and as we already discussed, at the transverse process of cervical vertebra, first cervical vertebra, your 2 is called 7B. So over here, this is the 7B. Now over here, it looks such a small volume because you have the digastric over here that obliterates the space over here. So I don't have any space to go posteriorly. So you're only going to basically end up including the vessels, the carotid, and the internal jugular vein in the space. And as we go up, yeah, a common pitfall over here is that people usually try and include this space. This is not the next space. This is the parapharyngeal space. This is not your jugular, anterior jugular, or your retrostyloid group of lymph nodes. Please make sure to always exclude the parapharyngeal space. This is lateral to the pharynx, pharyngeal this thing. So this is the parapharyngeal space. So include your vessels, stay out of the parapharyngeal space, and your digastric and your parotid gland. So ultimately, usually what you end up including is both your vessels, the jugular and the carotid. And also obviously stay behind the styloid. Like I mentioned, you don't have to include any normal structures. So that's why the name retrostyloid. So you go all the way up to the base of the skull or the jugular foramen. So this is the jugular foramen. Here are level 7B contour ends. So 7B, like we saw, is nothing but the cranial continuation of level 2. Okay, so now we move on to when to include level 2. So there's always a lot of controversy of what levels to treat and to what doses to treat. Now we have the VIIA guidelines that have simplified things. Many people follow this now. So for level 2, as I already mentioned, it's one of the most important nodal levels, and invariably you almost always, when you're treating the neck, you'll end up treating the level 2. So if you see in all of these volumes, irrespective of what site, irrespective of what nodal status, you will always have to treat level 2, because that is a nodal level that is at risk from most of the head and neck sites. So you'll always include level 2 in your contours. So the decision between ipsilateral versus bilateral level 2, this is again general principles applies to all the levels. So I'll discuss it once over here, but the same rules will apply to all nodal levels. So in well-lateralized oral cavity tumors, the general probability for contralateral nodal metastasis is less than 10%. So you can restrict yourself to ipsilateral neck RT unless you have huge nodes, huge ipsilateral nodes, obviously. In well-lateralized oropharyngeal soft palate, base of tongue, and posterior pharyngeal wall tumors, bilateral RT should be done. However, for the tonsil, which is a unilateral structure, you can consider unilateral treatment of the neck. In nasopharyngeal, hypopharyngeal, and laryngeal, in these are central structures, you will always treat bilateral neck. Okay, so the discussion between 2A and 2B, again, this guideline has provided some, some recommendation on this. So 2B, as already mentioned, is mainly associated with tumors arising in the oropharynx or the nasopharynx, and is less frequently involved in tumors of the oral cavity, larynx, or hypopharynx, especially those which do not have nodes in the level 2A. So in case of oral cavity and larynx, N0, N1, both 2B can be omitted. So your posterior border of level 2 will be your internal jugular vein posterior border. You do not have to go all the way up to the posterior border of the sternocleidomastoid. In case of N2A or N2B, that is ipsilateral nodes, contralateral 2B can be omitted. The same side will have to be treated because you have ipsilateral 2A nodes. For hypopharynx, you'll always, like I already mentioned, hypopharynx is a site which can go to 2B. So always treat ipsilateral 2B. If no contralateral nodal involvement, opposite 2B can be omitted. Same for larynx. If there is no contralateral nodal involvement, contralateral 2B can be omitted. And coming to level 7B, again, this has also been discussed. Level 7B is just the cranial continuation of level 2. The probability of having a node here is very, very less if you don't have a node in level 2. So level 7B, you have to treat only in case of bulky involvement, especially of the upper part of the level 2. Otherwise, you don't have to routinely treat level 7B in all cases. Coming to level 3. So like we saw, 7B was the cranial continuation of level 2, and level 3 is the caudal continuation of level 2. So level 3 is the name is middle jugular group. Again, the nomenclature is still retained. These are the lymph nodes located around the middle third of the internal jugular vein. And like we saw, 2 extended from the base of the skull to the carotid, 3 extends from carotid bifurcation to the omohyoid muscle, which is the clinical landmark. We'll see what landmark they gave it in their update. So basically, this space from the bifurcation to where the omohyoid crosses the vessels is your level 3. Again, this is a surgical landmark. So there's no subdivision of level 3 in this update. And the anatomical or the radiological landmarks are level 3 superiorly, the horizontal plane defined by the inferior border of the hyoid, which was the lower border of level 2. Inferiorly, up to the horizontal plane defined by the inferior border of the cricoid cartilage. Anteriorly or medially, it is restricted by the sternohyoid muscle, and then restricted by the sternocleidomastoid laterally. So it is the level 3 in our contouring guideline also, the middle jugular group. So the boundaries as per the contouring guideline, cranially again starts where 2 ends, that is caudal edge of the body of the hyoid bone. Caudally, it extends up to the caudal edge of the cricoid cartilage. Anteriorly, it extends till the anterior edge of the sternocleidomastoid or the posterior third of the thyroid muscle. We'll just see this in more detail. Posteriorly, again, as I already mentioned, all 2, 3, and 4 posteriorly will end where the posterior, where sternocleidomastoid ends posteriorly. Laterally restricted by the sternocleidomastoid, and medially will restricted by the paravertebral muscle, the scalenus in this case, and include the common carotid artery. So level 3 receives lymphatics from the level 2 and 5, and some efferent lymphatics from retropharyngeal, pretracheal, and the recurrent laryngeal nodes. It collects lymphatics from the base of the tongue, the tonsils, the larynx, the hypopharynx, and thyroid glands. So as already discussed, level 2 and level 3, you will electively treat. In any case, you're going to treat the neck. So this here is the level 2, caudal continuation of level 2, and posterior border is the posterior border of the sternocleidomastoid. So we'll see the anatomical boundaries first. So this here is the hyoid bone. So where the hyoid bone ends, your level 3 will start. So this is your strap muscle. So at this level, your level 3 will start. Again, it is the space between the sternocleidomastoid and the paravertebral muscle. So this space here is your level 3. Posteriorly restricted by the posterior border of the sternocleidomastoid. This posterior space, we'll see in a little while, is your level 5 or your posterior group of lymph nodes. So you have to stop at the posterior border of your sternocleidomastoid. So laterally, again, restricted by the sternocleidomastoid. Anteriorly, you extend up to the posterior 1/3 of the thyroid muscle. It's not clearly visible. We'll see in another cut whether it can be more clear. Over here, as I go anteriorly, here you don't have the sternocleidomastoid. So again, like we did for level 2, where you don't have any other structure limiting it, you would go all the way to the platysma and include this entire fatty space. Anteriorly, not go into the submandibular gland because that is the territory of level 1B or the submandibular group of lymph nodes. Medially, include the common carotid and exclude the paravertebral muscles and come back to the posterior border of the sternocleidomastoid. So these are the strap muscles. They are not very clear. It's very difficult. We've discussed in the module also, in the muscle anatomy module. It's very difficult to differentiate individual strap muscles on a CT scan. Even on MRI, it's not usually very clear because they are thin muscles. However, if you see the muscle that is attached to the thyroid is the thyrohyoid, and the muscle that is more anterior to it over here, the bulge that you can see over here, this is the sternohyoid. The sternohyoid runs all the way from the hyoid to the sternum. So it's sometimes possible to trace it down from the sternum, come cranially, and maybe you can see that bulge of sternohyoid. So when we say anterior, so posterior 1/3 of the thyrohyoid, where the sternohyoid inserts, the ridge that you can see over here approximately corresponds to that level. So anteriorly, you can include up to this cleft over here. So it looks like a cleft. So up to this level, it's not always very clear. It's more or less an approximate thing. So you come anteriorly up to here and include this space. So this is your level 3. So again, at this level, restricted by the sternocleidomastoid laterally. Anteriorly, it will go into the space between the sternocleidomastoid and the strap muscle. Obviously, not include any of these structures. Come back posteriorly, include the common carotid artery, exclude the paravertebral muscle, and posteriorly take it to the posterior border of the sternocleidomastoid. This here, as you can see, is a node. Since you know that over here you're supposed to have just 2 structures, it's very easy to say that this is a node, even if it is homogeneous in appearance. As I go down, you can see the thyroid gland here. Again, as already mentioned, for all normal structure, the rule stays. You're not going to include it in your volume. So over here, if I contour level 3, I'll contour this way, exclude the sternocleidomastoid, include the space between the sternocleidomastoid and the strap muscles. Come over here, exclude the thyroid, include the common carotid artery and the internal jugular vein, exclude the paravertebral muscles, and come posteriorly up to the posterior border of the sternocleidomastoid, beyond which is your posterior group of lymph nodes. So we'll see the contours. So this is your level 2, since you can still see the hyoid. Once your hyoid ends, level 2 becomes level 3. So this is your level 3 group of lymph nodes. Laterally sternocleidomastoid, where there is no sternocleidomastoid, you extend up to the platysma. Like I mentioned, this cleft over here, approximately the sternohyoid cleft approximately comes to the posterior 1/3 of the thyrohyoid muscle. So anteriorly, I extend up to here, exclude the bone, thyroid cartilage, sorry, exclude the thyroid cartilage, include the internal carotid, sorry, the common carotid artery, and exclude the paravertebral muscles. When you are contouring medial border in level 2, 3, and 4, always restrict to the common carotid medial border or the internal carotid artery medial border. Don't go beyond it. Don't include this space, because we'll see in a while that is some other nodal level. So always just give enough margin to include the entire vessel. You don't have to contour beyond it. So again, the space between the strap muscle and the sternocleidomastoid is very thin over here. So I could not extend my contour beyond. So medially restricting by the, or anteriorly restricting by the anterior border of the sternocleidomastoid, posteriorly restricting by the posterior border of the sternocleidomastoid, laterally by the sternocleidomastoid, medially by the paravertebral muscles, and making it a point to include the common carotid artery and excluding the thyroid gland. So this is level 3, which at the lower border of the cricoid cartilage continues as level 4A. So indications for treatment of level 3, as same as level 2, you will include it in all cases. Even if you're treating it electively, if you're treating the neck, you will include level 3. And ipsilateral versus bilateral RT rules remain the same. So now we jump on to level 4. Can I continue?
Yeah, you can continue.
Yeah. So level 4 is the caudal continuation of level 3. So in the 1991 Thomas Robbins paper, again, level 4 was, there was no division of level 4. It was all the way from the lower border of the cricoid, as we saw, all the way down up to the clavicle. So that was the level 4, and there was no subdivision of level 4 as per the update of the surgeon's update. And the radiological landmarks for level 4 are as follows. Superiorly, the horizontal plane defined by the inferior border of the cricoid cartilage, inferiorly up to the clavicle, and again, anterior and the posterior border remain same as we saw in level 2 and 3. Coming to the contouring guideline, so this is your level 4A and level 4B. So level 4A and is the lower jugular group, and level 4B is your medial supraclavicular group. So this distinction between 4A and 4B, as we saw, was not done by surgeons. It was done by radiation oncologists. This division was done based on the observation that surgeons usually do not dissect all the way up to the clavicle or all the way up to the manubrium sternum. They usually restrict to approximately 2 centimeters above the manubrium sternum. So that is why this division of 4A and 4B was made. So unless you have a node in your 4A that is till 2 centimeters above the manubrium sternum, you don't have to include that space between the manubrium sternum and 2 centimeters from it. So that's why this distinction was made. And also it has clinical implications. Having a level 4 B node has more ominous prognosis, and usually can be a sign of metastatic disease from your breast or your GI malignancies, especially when it is isolated. So level 4A is the lower jugular group of lymph nodes, which is in line with the 7B, level 2, and the level 3. So again, extends from the cricoid cartilage caudal border, which was the caudal border of level 3, till the 2 centimeters cranial to sternal manubrium. Again, anterior, posterior, lateral, and medial borders, the principles remain the same. We'll see it in more detail when we see the contours. Level 4B is the medial supraclavicular group. So for till 4A, you had lower jugular group. Now 4B is your medial supraclavicular group. So cranially, it starts from where the 4A ends, that is 2 centimeter cranial to manubrium sternum, and extends all the way up to the manubrium sternum. So anteriorly, again, it's limited by the sternocleidomastoid anterior border, and these principles remain the same. We'll see it on the contours. So this is the same discussion that we did, how the distinction between level 4A and 4B was made. So level 4A receives efferent lymphatics primarily from 3 and 5, and some efferent lymphatics from the retropharyngeal, pretracheal, and the recurrent laryngeal nodes, and also collect nodes from the hypopharynx, the larynx, and the thyroid gland. And they are at high risk for harboring metastasis from cancers of the hypopharynx, larynx, thyroid, and the cervical esophagus. Rarely, metastasis from the anterior oral cavity may manifest in this location with minimal or no proximal nodal disease. So oral cavity disease, usually when it metastasizes to 4A, you already have level 2 and level 3 nodes. So it is quite unusual for oral cavity tumor, especially to have isolated level 4A nodes, though it can happen. Level 4B is the medial supraclavicular group of lymph nodes. It's the caudal continuation of the level 4A and extends all the way up to the manubrium sternum. So this space is your level 4. So caudal continuation of your level 3 all the way up to the clavicle. So in this, the distinction, the demarcation between 4A and 4B is not pointed. Okay, so we'll see the anatomy. So this is the cricoid cartilage. Once you stop seeing the cricoid cartilage is where your level 4A contouring will start. Again, like I mentioned, it's the same area that you're going to contour. So deep to the sternocleidomastoid. Over here, you'll go into space between the sternocleidomastoid and the strap muscles. Exclude the thyroid gland, include both the vessels, exclude the paravertebral muscles, and come laterally up to the posterior border of the sternocleidomastoid. Now, if you notice over here, everywhere it's given cranial, caudal, cranial, caudal, cranial, caudal. That is because your sternocleidomastoid is an oblique structure. So as we saw in the cranial cuts, it was more of an anterior-posterior structure. And as we go down, it is twisting around the neck, and now it is it is a right-left structure or mediolateral structure rather. So now whatever was your anterior boundary now becomes your medial boundary. So this is what I mean to say. So now in the caudal limit, your medial, these are your limits now. This is your medial. So the medial border of the sternocleidomastoid is now the medial border. The lateral border of sternocleidomastoid is now the lateral border. And posteriorly, you go all the way up to the paravertebral muscles, and anteriorly restricted by the sternocleidomastoid. Again, exclude the thyroid gland and include the vessels. And over here again, you do not have to include this space. You just have to include the common carotid artery. So just include the medial border of the common carotid artery, and that will be your level 4A. So add 2 centimeters cranial to the manubrium sternum, which I've counted on this cut, will your level 4B start. So at this level, your level 4B will start. Okay, we'll see the contours now. So this is your level 4A. So like I mentioned, now this is your anterior border, this is your posterior, this is your medial, and this is your lateral. So again, laterally and anteriorly restricted by the sternocleidomastoid, medially till the medial border of sternocleidomastoid, posteriorly exclude the vertebral muscles, in this case the scalenus anterior, and include the nodes, and if there are any, and include the vessels, and exclude the thyroid, of course. And like I said, don't include this space. This is some other nodal level. You just have to include the common carotid artery medial border. So at 2 centimeters cranial to manubrium sternum, you will have the level 4A will become the level 4B. So this is the level 4B over here. So over here, since I'm not able to, since you have the clavicle, now your clavicle is anteriorly restricting. As you can see over here, the deep aspect of the clavicle will not allow me to contour anteriorly all the way over here. So I restrict my contours up to this level, up to the clavicle. So now level 4B, especially in the lower neck, your contours will only include mainly your common carotid and your internal jugular vein. You usually won't have a lot of fatty space here. So this is your level 4B. When you see the manubrium sternum, you stop contouring level 4B. So when to include level 4A and 4B? So in case of oral cavity tumors, if it's an N0, include ipsilateral 4A for tumors extending into the oropharynx. If there is no extension into the oropharynx for an N0, you can omit level 4A. If N1, again include ipsilateral 4A for tumors extending into the oropharynx, or if the positive node is located in the level 3, and include level ipsilateral 4B if 4A is involved. If N2A or N2B, that is a single node which is more than 3 centimeters, or multiple ipsilateral nodes, then still include ipsilateral 4A in all cases, and include ipsilateral 4B if the 4A is involved. If N3, include ipsilateral 4A in all cases, and include ipsilateral 4B only if 4A is involved. Coming to oropharynx, in oropharynx you always include 4A irrespective of the nodal status, because the risk of lymph nodal metastasis in this level from the oropharynx is much higher. And you include level 4B on the side with the involvement of the 4A. So as I already mentioned, the reason for this distinction was that you don't have to treat all the way up to the manubrium sternum if you don't have nodes that are in the level 4A. So you treat 4B mainly when you have nodes in the level 4A. Otherwise, you don't have to extend all the way up to the manubrium sternum. In hypopharynx, again, you will always include 4A, and 4B should only be treated when you have involvement of the level 4A on the same side. In larynx, again, always include 4A, 4B only on the side with involvement of 4A. Nasopharynx, always include 4A. It can be omitted on the side with no nodal involvement though. And 4B should be included on the side with involvement of level 3 or 4A, and in all cases with N3 nodal disease. So now we'll quickly see, we have seen the lateral group of lymph nodes, or basically the retrostyloid, the upper jugular, the middle jugular, the lower jugular, and the medial supraclavicular group of lymph nodes. So we've seen first this group, then this, and this. So all of this have common boundaries. It's very easy to remember. They are just the cranial and caudal extensions of each other. And posteriorly, they are restricted by the sternocleidomastoid. And posterior to this group of lymph nodes will be your posterior cervical group of lymph nodes. And anterior to them will be an anterior group of lymph nodes. So I've just put them together just to get a more clearer idea. So this is your retrostyloid. At the caudal edge of the first cervical vertebra, it becomes the level 2. So this is the level 2. At the caudal edge of the hyoid, it becomes the level 3. At the caudal edge of cricoid, it becomes level 4A. And 2 centimeters cranial to manubrium sternum, your 4A will become 4B. So it's always easy to remember them as a continuous structure, 7B, 2, 3, and 4, then you don't confuse. So now coming to level 5. So level 5 is basically, we have seen 2, 3, and 4. So posterior to that, this entire group of lymph nodes is your level 5. So level 5 was again first described in the Robbins paper in 1991. So they have called it the posterior triangle group. It comprises mainly of nodes that are located along the lower half of the spinal accessory nerve and the transverse cervical vessels. And since they described it all the way up to the clavicle, level 5, they had no divisions, no subdivisions. So this included your supraclavicular, the lateral supraclavicular also. This is your medial supraclavicular, and this here lower down is your lateral supraclavicular. In the update, they divided 5 into 5A and 5B based on the 5, into levels 5A and 5B. The superior component 5A predominantly contains the spinal accessory lymph nodes, whereas 5B contains the transverse cervical lymph nodes and the supraclavicular lymph nodes. And they used the lower border of cricoid cartilage as the distinction between 5A and 5B. We'll see how this has changed for our contouring guidelines. So over here, 5A is above the cricoid cartilage, and 5B up to the clavicle is below the cricoid cartilage to the clavicle. So radiological landmarks as per the surgical paper, superiorly from the convergence of the sternocleidomastoid to the trapezius and the trapezius muscle. This is where you start seeing that space posterior to the sternocleidomastoid. Inferiorly up to the lower border of the cricoid cartilage is 5A. Beyond that, up to the clavicle is your 5B. And obviously anteriorly will be the sternocleidomastoid posterior border, and posteriorly it will be restricted by the trapezius muscle. So the contouring guidelines now have divided into 3 groups. So the level 5A, the level 5B, and the level 5C. So now the 5A is basically corresponds to the spinal accessory group of lymph nodes. 5B corresponds to the transverse cervical group of lymph nodes, and 5C corresponds to the lateral supraclavicular group of lymph nodes. Again, so basically in the previous surgical guideline, you saw there was a 5A and there was a 5B. So 5B had both 5B and 5C of this. So this change was made based on the observation that 5B and 5C are different group of lymph nodes. Your surgeons, when they usually operate 5B, especially if they are doing it electively, they usually just cover the transverse cervical group of, the transverse cervical vessels and don't go below it. So the lateral cervical supraclavicular group is not routinely dissected. So level 5 means the 5A and the 5B. So cranially from the caudal border, cranial edge of the hyoid bone, it extends from the cranial edge of the hyoid bone to the caudally to the plane just below the transverse cervical vessels. So your transverse cervical vessels should be inside your level 5. And to be precise, level 5B. 5A spinal accessory, 5B is transverse cervical. Anteriorly, it starts at the posterior edge of the sternocleidomastoid and posteriorly goes up to the trapezius muscle. Laterally, again, restricted by the platysma. Since this is posterior to the sternocleidomastoid, you don't have any muscle there. I mean, you don't have any other muscle there. You have only the platysma. In some cases, you will only have the skin. And medially, again, it will be restricted by the paravertebral muscles. 5C also is known as the lateral supraclavicular group. It extends below the transverse cervical group of vessels and extends caudally up to 2 centimeter cranial to the manubrium sternum. So this is basically the caudal border of 4A. So what this means is, as if you can just imagine, our supraclavicular fossa is basically an oblique structure. So laterally you have a higher boundary. So the lateral supraclavicular nodal station ends 2 centimeter above the manubrium sternum, and the medial supraclavicular nodal station starts 2 centimeter cranial to the manubrium sternum. So again, the same as we have already discussed, the distinction between 5A and 5B. So level 5 receive efferent. So 5, whenever we say 5, we are meaning 5A and 5B. So for contouring and for surgery, there's no distinction between 5 and 5B. When you say you're treating 5 with RT or with surgery, you usually mean 5A and 5B, but you'll omit out 5C unless specified. So level 5 receives efferent lymphatics from the occipital and the retroauricular nodes, as well as those from the occipital and the parietal scalp, the skin of the lateral and the posterior neck, and the shoulder, the nasopharynx, the oropharynx, and the thyroid gland. Level 5 lymph nodes are at high risk for harboring metastasis from cancer of the nasopharynx and oropharynx. Like I mentioned, nasopharynx and oropharynx have a propensity to go to the posterior nodes. So like we discussed, level 2B in case of level 2, because that is posterior, and also the level 5 group of lymph nodes. So 5C is the lateral supraclavicular group of lymph nodes. So this basically is the level 5 and 5B. This is according to the surgery landmark. So there's no 5C in this. Okay, so one important thing is it's always a controversy to identify the transverse cervical vessel and to what level to include the transverse cervical vessels, since it moves across the neck. So I'll just try to demonstrate that. So again, this you've already seen from the arch of the aorta. You have 3 branches. This here is the brachiocephalic trunk. This here is the common carotid. This is the right subclavian. So I'm going to track the right subclavian artery now. So the right subclavian artery gives out branches. It gives out the vertebral artery, the internal mammary artery, and this here is the transverse cervical artery. So you can just see this vessel over here. It's moving laterally. This is nothing but the transverse cervical artery. So you have to include this. So this is your lateral border of your sternocleidomastoid. So lateral to this is your level 5. Medial to this was your level 4. So this is your level 5. So at this level, you have to make sure you have to include the transverse cervical vessel in your contour. So which means you have to include 5B. If you omit out transverse cervical vessels, it means you're omitting out level 5B. So this I'm again continuing to go cranially. So I have to basically include my level 5B till this level. It will become much more clear when I show it on a coronal section. See, this is the transverse cervical vessel. So it goes on and branches into the posterior triangle. So it's very difficult to know where to stop. So people randomly stop at various sites. So this over here is what I mean. So this is your level 5 territory, lateral to the sternocleidomastoid. So in this territory, you have to make sure you include the entire transverse cervical vessel. If you put your border over here at the cricoid, approximately, this will mean you are putting the lower border of 5A. This is your lower border of 5B, and 2 centimeters from the manubrium sternum, somewhere around here, will be your lower border of 5C. So again, it starts at the cranial board, the cranial edge of the body of the hyoid. So this is the hyoid bone. So over here, your level 5 will starts posterior to the sternocleidomastoid. Till now, we were seeing this space. So it's this space behind the sternocleidomastoid. So between the sternocleidomastoid and the trapezius, this muscle is the trapezius. And this is the trapezius on the opposite side. So this space here. So again, over here, in this space, laterally, like I said, by the skin or the platysma, medially by the paravertebral muscles, anteriorly by the posterior border of the sternocleidomastoid, and posteriorly by the trapezius. So again, this space is your level 5. Okay, so it becomes a little tricky over here. So there's always a discussion on whether to include this depression over here or just to go up to the anterior border of the trapezius. The guideline very clearly says the posterior is the anterior border of the trapezius muscle, or the anterolateral, as mentioned in various other literature. So you have to basically include only up to here. This is what the atlas shows. The consensus guideline atlas also doesn't include this depression, this space between the scalene, the levator scapulae and the trapezius muscle. It should not include this. But if you see the nasopharynx contouring atlas, they have included this. So basically, this goes on to mean that if you have this level 5 to be at higher risk of nodal metastasis, such as in nasopharynx, or when you actually have nodes in level 5, it may make sense to include all this space. But otherwise, when you're treating level 5 electively, you don't have to include this space, and just restrict yourself posteriorly to the anterior border of the trapezius. So you come like this. So caudally, you go just below the plane of the transverse cervical vessels for your level 5B, below which will be your 5C, which continues up to 2 centimeters cranial to the manubrium sternum, which we'll have to count. Okay, so we'll go to the contours. So this here is your level 2. So behind the level 2, at the cranial edge of the hyoid bone, your level 5 starts. So it's posterior to the nodes, and I've extended all the way laterally to the skin because there's no platysma clear over here. So this space between the sternocleidomastoid and the trapezius is your level 5. It becomes more prominent as you scroll caudally. So this entire space, you can see some nodes here. So this entire space between the sternocleidomastoid and the trapezius is your level 5. Medially restricted by the paravertebral muscle, levator scapula in this case, and laterally by the platysma or the skin. So like I said, here I've just put my posterior border at the anterior border of the trapezius. I'm not including this depression. I would have if there were nodes over here, or if this was a site which has a high risk for posterior nodal metastasis. So again, laterally by the platysma, posteriorly by the trapezius, anteriorly by the sternocleidomastoid, and medially continuous with your upper middle or lower jugular group of lymph nodes. So this is your level 5 and 5B. It includes the transverse cervical vessels, and below that you will have the level 5C. So this here is the level 5C. Again, laterally it will restrict by the clavicle, anteriorly by the skin or the platysma, medially to the lateral border of the sternocleidomastoid, and posteriorly by the paravertebral muscles. When the clavicle crosses anteriorly, you will restrict by the clavicle. You don't have to contour to the skin. So at 2 centimeters cranial, where the 4A becomes the 4B, you will stop contouring the level 5C. So we'll see what are the indications for treatment of level 5. So for oral cavity, in a case of N0 and N1, we do not treat level 5. In case of N2A and N2B, that is ipsilateral nodes, we'll include ipsilateral 5A and 5B, which we could still consider omitting it if the positive lymph nodes are higher up in level 1 and level 2. And if there are N3 nodes, then ipsilateral 5A and 5B should be treated in all cases. In case of hypopharynx, always include 5A and 5B except on the N0 side. In oropharynx and larynx, if N0 and N1 similar to oral cavity, you do not include, because like we already discussed in the beginning of the class, this posterior group of lymph nodes, usually oral cavity and larynx do not go to them unless they have nodes in the anterior groups. So in N0 and N1 for both oral cavity and larynx, you will omit level 5. But if there are ipsilateral nodes, then you will include ipsilateral 5A and 5B in all cases. And even if it is N3, you will include ipsilateral 5A and 5B in all cases. For nasopharynx, you will always include 5A and 5B. And nasopharynx is the only indication where you actually treat level 5C, because there is when there is involvement of 5A and 5B. So moving on to level 7A. So level 7A nomenclature was not there in the first guideline in 1991. Subsequently, in the update, they mentioned the name as retropharyngeal. However, they did not assign a number to it, so it was not called level 7 at that time. Coming to the contouring guideline, the consensus guideline defined 7A as a retropharyngeal group of lymph nodes and divided it from the retrostyloid group of lymph nodes. So boundaries of the retropharyngeal group of lymph nodes, cranially it starts at the upper edge of the body of the hyoid, of the C1 or the heart palate, and caudally it extends up to the cranial edge of the body of the hyoid bone. Anteriorly, it extends from the posterior edge of the superior or middle pharyngeal constrictor, posteriorly up to the longus capitis and the longus colli muscle, which are the prevertebral muscles. Laterally restricted by the medial edge of the internal carotid artery, and medially restricted by a line parallel to the lateral edge of the longus cavity muscle. So basically your retropharyngeal is divided into a medial and lateral retropharyngeal group of lymph nodes by this line. The medial retropharyngeal group of lymph nodes is an inconsistent group. You usually don't have nodal metastasis there unless you have metastasis in the lateral retropharyngeal group of lymph nodes. So it's usually not recommended for contouring. The retropharyngeal nodes that are described in this guideline basically are the lateral retropharyngeal group of lymph nodes. So they receive efferent lymphatics from the nasopharynx, the eustachian tube, and the soft palate. The nodes are at risk of harboring metastasis from cancers of the nasopharynx, the posterior pharyngeal wall, and the oropharynx. So though it might have looked a little complicated till now, we were dealing with easy things. So this is also not very complicated actually. So this here anteriorly is your pharynx. So this is your pharyngeal wall, and here you have the pharyngeal constrictor muscle. So this is your anteriorly pharynx. This is your vertebral body, and anterior to the vertebral body, you have your prevertebral muscles. So this is the longus cavity or the colli based on the level that you're talking about. So this is the prevertebral muscle, and anterior to the prevertebral muscle is the prevertebral fascia. So this space between the prevertebral fascia and the buccopharyngeal fascia, or to simplify it, between the prevertebral muscle and the pharyngeal constrictor muscle, is nothing but your retropharyngeal group of lymph nodes. So posterior to pharynx, retropharyngeal, is your retropharyngeal group of lymph nodes. And we saw till now, I was constantly mentioning that you include only up to the medial border of the internal carotid artery, because medial to that will be your another nodal level. So this another nodal level that I was talking about was level 7A, from the C1 to the cranial edge of the hyoid bone. So this space medial to the carotid artery is your, and between the pharyngeal constrictor and your strap muscles, between your pharyngeal constrictor and your prevertebral muscle, is your retropharyngeal group of lymph nodes. So it's not very difficult actually. So it starts at the upper edge of the body of the C1. So over here, you can see this thin space. So this here is the pharynx, this is the pharyngeal constrictor muscle. And this bulge posteriorly on the vertebral body is nothing but the prevertebral muscle. So this thin space that is medial to the carotid and between the pharyngeal constrictor muscle and the prevertebral muscle is nothing but your prevertebral group of lymph nodes. Sorry, retropharyngeal group of lymph nodes. I'm sorry. This is your retropharyngeal group of lymph nodes. So usually it may not be very prominent in certain cuts, especially if you have nodes that are compressing spaces, but you can always scroll up and down and look for a place where you can see this thin space. So like in this case, you can see this thin space over here that is medial to the carotid, posterior to the pharyngeal constrictor muscle, and anterior to the prevertebral muscle. So this is nothing but the retropharyngeal group of lymph nodes. So medially, like we already mentioned, it has to extend all the way up to the line parallel to the lateral edge of the longest cavity muscle. But this, however, I'm not sure, it's very difficult to usually follow this because you sometimes the lateral edge of the longest cavity muscle lies lateral to the carotid artery. So it's not possible to have a lateral border here and a medial border that's lateral to it. So usually what is done in common practice is you, whatever space you do see, you contour that space and not extend all the way up to the midline, because this will be your medial retropharyngeal group of lymph nodes. So contour up to the space, and if you can't see the space, maybe 0.5 to 0.8 centimeter usually makes sense. Just make sure not to include this medial group up to the midline, but using this as a lateral, sorry, as a medial landmark, it's not very consistent. So this is the prevertebral muscle over here, and this is the pharyngeal constrictor muscle. So this space, this thin space, the dark space that you see over here is the retropharyngeal group of lymph nodes, and it's always medial. Level 2, when we were contouring till the medial border of the carotid. Medial to that is your retropharyngeal group of lymph nodes. For people who are having difficulty in understanding this muscle anatomy, we already released a module on the muscles. You can please go back and then maybe watch this lecture. It will be much more easier for you. So again, this space, this whole thing is your retropharyngeal space. Here, this is the medial retropharyngeal space, and this is your lateral retropharyngeal space. So we'll see the contours now. So this is your level 2, retrostyloid group of lymph nodes, because this is above the level of the transverse process of the first cervical vertebra. So medial to the carotid at this level between the pharyngeal constrictor and this bulge, which is the prevertebral muscle, the longest capitis in this case, is your retropharyngeal group of lymph nodes, or the 7A. So you can still see over here. So here at the transverse process of first cervical vertebra, your level 7B, the retrostyloid became the level 2. So the medial border of which is the internal carotid artery, medial border, medial to which is your retropharyngeal. So you can see this thin space. You can even see it on the opposite side. So this thin space between the pharyngeal constrictor and the prevertebral muscle is your retropharyngeal. So people are usually intimidated by this nodal level for some reason, but it's actually very, very easy to draw. So once you draw level 2, all you have to do is just include this in all your cuts. Just go medially and include it up to some distance from the midline. So just include this thin space. So it's very, very easy actually. So it's that contoured all the way up to the caudal cranial edge of the body of the hyoid bone. So here I'll see the caudal edge of the, cranial edge of the body of the hyoid bone, and I'll stop contouring the retropharyngeal group of lymph. So for indications for treating retropharyngeal group of lymph nodes in oral cavity and for larynx, retropharyngeal group of lymph nodes are not routinely treated. In oropharynx, there are 2 indications. You treat retropharyngeal nodes when you have posterior pharyngeal wall involvement, or when you have N2A disease or beyond. And in hypopharynx, you should treat it when you have posterior pharyngeal wall involvement or you have node plus a nodal disease. In case of nasopharynx, since this is a very high risk of metastasis to this level, level 7A is always treated. So we are done with the lateral group of lymph nodes. We are done with the posterior group of lymph nodes, and we are done with the retropharyngeal. So now we are left with the anterior group, that is the level 1A, 1B, the submental and the submandibular, and the level 6A and 6B. So first we'll finish off with the level 1A and 1B. So level 1 was again defined by the Thomas Robbins paper in 1991. They did not give a separate number to them. They did not demarcate them, but called level 1 as both submental and submandibular group of lymph nodes. So submental group of lymph nodes, basically 1A, as they called it in the subdivision in the update. So superiorly extending from the symphysis of the mandible, inferiorly up to the body of the hyoid bone, and it lies between the two anterior bellies of the digastric. Level 1B basically lies between the anterior belly and the posterior belly of the digastric. In the contouring guideline, you have 1A, which is called the submental group, and 1B, which is the submandibular group. 1A cranially starts at the mylohyoid muscle, caudally extends up to the platysma muscle, because that forms the floor of your submental group of lymph nodes. Anteriorly extends up to the symphysis menti, posteriorly up to the body of the hyoid bone or the mylohyoid muscle when you can appreciate it. Laterally restricted by the medial edge of the anterior belly of the digastric. Again, I'll show some diagrams that will make it much more clear. Level 1B is the submandibular group of lymph nodes. It has the submandibular gland inside it. Cranially, it extends where the submandibular gland starts, and caudally, it extends till the caudal border of the hyoid bone or the caudal border of the submandibular gland, whichever is more caudal. Anteriorly till the symphysis menti, posteriorly till the posterior edge of the submandibular gland. As we saw, posterior to this is your level 2. Laterally, it is restricted by the mandible or the masticator muscles. In this case, it will be the medial pterygoid muscle. So level 1A is basically a median region. It's a single nodal. It's not the right and left. So it's a median region located between the two anterior bellies of the two digastric muscles on both sides. So nodes in level 1A drain the skin of the chin, the mid lower lip, the tip of the tongue, and the anterior floor of the mouth, and is at greatest risk of harboring metastasis from cancers arising from the floor of the mouth, the anterior oral tongue, the anterior mandibular alveolar ridge, and the lower lip. The 1B contains the submandibular group of lymph nodes located in the space between the inner side of the mandible laterally and the digastric muscle medially. Again, I'll show it in the diagram. It will be much more clear. It sounds a little confusing now. Level 1B receives efferent lymphatics from the level 1A, the lower nasal cavity, the hard and the soft palate, the maxillary and the mandibular alveolar ridges, the cheek, the upper and lower lips, and most of the anterior tongue. And they are at greatest risk of developing metastasis from oral cavity cancers, nasal cavity, soft tissue structures of the midface, and the submandibular gland. So this here, medial to the anterior belly of the digastric is your 1A, and between the anterior and the posterior belly of digastric is 1B. So this diagram will make it much more clear. So this fan-shaped muscle that you can see is the mylohyoid. It is the floor of the mouth. It forms the floor of the mouth. So below this muscle or superficial to this muscle is your submental and your submandibular group of lymph nodes. So superficial to this muscle, this space between the two anterior bellies of digastric up to the hyoid bone, this space is your submental group of lymph nodes or your level 1A. And this space lateral to the anterior belly of digastric and medial to the posterior belly of digastric. So this space, again superficial to the mylohyoid, is your level 1B or your submandibular group of lymph nodes. So cranially, it will start at the mylohyoid muscle. So you can see the mylohyoid muscle here. So this is the submandibular gland. This here you can see the anterior belly of the digastric. So over here, I'm going cranially again. So over here, you can't see any space over here because here the mylohyoid muscle is inserted onto the mandible. But as I scroll caudally, you can see this space. So this means this is below the mylohyoid muscle. So this space has to be included when you're including level 1B. And obviously you have to include the submandibular gland. And in this case, posteriorly go up to the digastric muscle, or in this case, you will be restricted by the parotid gland. So again, this space is now below, the space that you can see is below the mylohyoid muscle, so or the floor of the mouth. So you have to include this space, include the submandibular gland, posteriorly up to the posterior belly of digastric anterior border, and laterally restrict yourself to the muscle, the masticator muscle, the medial pterygoid. Don't include the medial pterygoid again. And here laterally again restrict by the medial border of the mandible. So this here is the anterior belly of digastric. This here is the posterior belly of digastric. They unite at a common tendon. So this is the right anterior belly of digastric. This is the left anterior belly of digastric. This space between them, anteriorly limited by the platysma, this space over here is nothing but the submental group of lymph nodes. And this space between the anterior belly and the posterior belly of digastric, including the submandibular gland, and is laterally restricted by the platysma, this space is your 1B or your submandibular group of lymph nodes. So caudally, you will contour till where you see the submandibular gland. So once you see the once you stop seeing the submandibular gland, you stop contouring the level 1B or the cartilage of the hyoid bone, whichever is much lower. In our case, the submandibular gland extends much lower because of the position of the neck. So you'll contour level 1B till here. So like I mentioned, so including the submandibular gland over here, posteriorly, this is the posterior belly of digastric. So almost extending up to the posterior belly of digastric, laterally restricted by the mandible, anteriorly restricted by the anterior belly of the digastric. So this entire space is your level 1B or your submandibular group of lymph nodes. This is your left anterior belly of digastric, and this is the right anterior belly of digastric. The space between these two anterior bellies and anteriorly restricted by the platysma is your level 1A or the submental group of lymph nodes. So as you go down again, make sure you include the submandibular gland and exclude the extrinsic muscles of the tongue. Laterally include all the way up to the platysma and anteriorly restrict to the anterior belly of the digastric. So till I see the submandibular gland, I'll contour the submandibular group of lymph nodes. So till here is my submental and a submandibular group of lymph nodes. So we'll see when to treat them in oral cavity, because the risk of involvement is very high. So you always treat level 1. In case of oropharynx, level 1B is included in cases of all patients with multiple nodes or nodes more than 3 centimeters in size. In N1, 1B is treated only if the tumor extends into the oral cavity, because then, even though it's an oropharynx tumor, the involvement of the involvement of oral cavity portends higher risk of level 1 metastasis. If there is N0, 1B is treated if tumor extends into the oral cavity. In case of hypopharynx, level 1B included in all N plus on the side of lymphadenopathy. And in larynx, level 1B is treated if there is anterior involvement of the level 2. Nasopharynx, you treat 1B only in cases of involvement of N3 disease. In N1 and N2, you treat 1B only if there is submandibular gland involvement, or there is involvement of structures that eventually drain to the level 1B, such as the oral cavity, or if there is anterior involvement of level 2 nodes. So the last nodal level that we'll be covering today, so the level 6. So again, level 6 is nothing but the caudal continuation of your level 1. So level 6 was again defined in the 1991 Thomas Robbins paper. So the level 6 anterior compartment group is the group comprises the lymph node surrounding the midline viscera of the neck, extending from the level of the hyoid bone superiorly to the suprasternal notch inferiorly. On each side, the lateral boundary is the medial border of the carotid sheath. So again, you saw that the retropharyngeal group of lymph nodes stops at the cranial edge of the hyoid. But below the hyoid, when you have the nodal, the fatty space that is medial to carotid artery, that is nothing but your level 6. So coming to this update, level 6, the radiological landmarks superiorly by the hyoid bone, inferiorly to the suprasternum, anteriorly or medially by the common carotid artery. So in the contouring guideline, it's the level 6A, which is the anterior jugular group of lymph nodes, and 6B is the paravisceral, that is the prelaryngeal, pretracheal, and the paratracheal group of lymph nodes. So level 6A starts at the caudal edge of the hyoid bone or the caudal edge of the submandibular gland. Like I mentioned, it is the caudal continuation of level 1A. So wherever 1A ends and 1B ends, you will see the level 6A. Caudally, it extends all the way up to the sternal manubrium. It anterior border is the skin or the platysma, and posteriorly the strap muscles. So it is this space between the platysma and the strap muscles between the two sternocleidomastoids. We'll see it on the CT scan. Level 6B is extends from the caudal edge of the thyroid cartilage. So it extends much lower down. So caudal edge of the thyroid cartilage, it starts and ends again at the manubrium sternum. Anteriorly, it is restricted by the posterior aspect of the strap muscles, and posteriorly, it is restricted by the your viscera. Laterally, common carotid arteries, like I mentioned, it is medial to your vessel, and medially, it is restricted by the trachea or the esophagus. So this here is the anterior group of lymph nodes. So this is your submandibular gland. Once you stop seeing the submandibular gland, you will start seeing the level 6A and 6B. So in this patient, this space over here, it's very prominent. You will not see this in all patients. We specifically chose this patient because of this clear neck spaces. So it's usually much thinner because our patients are usually not, don't have such clear fat spaces. So this space between the strap muscle and the platysma, This is the platysma and this is the strap muscle. So this space over here extending between the two sternocleidomastoids. So this is one sternocleidomastoid, this is the other sternocleidomastoid. So this entire space is nothing but your anterior jugular group of lymph nodes or your level 6A. Here you don't yet have the 6B because that will start once your thyroid cartilage ends. So you only have 6A over here from this. So once your thyroid, so again, we'll continue to contour 6A all this till the manubrium sternum. So this space, this thin space between the platysma and the strap muscles and laterally between the two sternocleidomastoids is your level 6A or your anterior jugular group of lymph nodes. So this you have to contour up to the manubrium sternum. But once your thyroid cartilage ends, you'll also start contouring the level 6B. So it is this space medial to the carotid artery. So this space over here is your level 6B. Like we saw, medially it is restricted by the viscera, anteriorly also by the viscera, posteriorly by the paravertebral muscles, and laterally by the common carotid artery. So this space is the 6B. So this here anteriorly is the 6A, this here posteriorly is the 6B. So once you don't have the thyroid gland, in this case, you have the strap muscle that is the only structure that remains separating the 6A from the 6B. So anterior to the strap muscle and between the two sternocleidomastoid and posterior to the platysma. So this space here is your level 6A, and posterior to your strap muscles and medial to your carotid. So posterior to the strap muscle and medial to the carotid and lateral to your viscera, in this case the trachea, is your level 6B. So again over here, this is the 6B, restricted laterally by the vessels, and anteriorly over here between the two sternocleidomastoids and anterior to the strap muscles, posterior to the platysma is your 6A. And these continue all the way up to the manubrium sternum. So once you start seeing the manubrium sternum, you'll stop contouring these levels. So we'll see the contours. So this is your level 1A and level 1B. So once you stop seeing the submandibular gland, now your level 1B will end and you will see your level 6A. So level 6A, like I mentioned, between the platysma and the strap muscle and between the two sternocleidomastoid. In this case, it's up to here because if you remember, we had contoured level 3 all the way up to the posterior 1/3 of the thyroid muscle. So that border joins over here. So between the two sternocleidomastoids, posterior to the platysma, anterior to the strap muscle is your level 6A. Your level 6B only starts when you stop seeing the thyroid cartilage. So here your level 6B starts. It's nothing but medial to the carotid artery. So again, this entire space, posteriorly by the vertebral muscles, medially by the viscera, anteriorly again by the viscera, and laterally by the carotid is your level 6B. So over here, like I mentioned, your strap muscle is the only structure that separates 6A from 6B. So include all this fatty space that is medial to the vessels and lateral to your viscera, in this case the trachea and the esophagus. So over here, when you contour the level 4, the level 4 will include the vessel and it will be continuous with your level 6B. So over here like this will be your level 4. So once you see the manubrium sternum, you will stop contouring the level 6A and the level 6B. Okay, that's all. If there are any questions. Okay, sorry, I'll just see the indications for level 6A and 6B treatment first. So oral cavity, level 6 is not routinely treated, so as for oropharynx and nasopharynx. In hypopharynx, you will treat level 6 if there is involvement of the pyriform sinus apex or the postcricoid or the cervical esophagus. And in larynx, you treat level 6 if there is transglottic or subglottic extension of the primary. So it's whenever you're treating it for hypopharyngeal and laryngeal patients, you always treat bilaterally. So thank you. If there are any questions, I know I'm open to it.
Thank you, Dr. Tosif, for the comprehensive demonstration of the lymphatic spaces and delimiting boundaries. So, as always, the amount of anatomy involved is huge, and your video is going to be an extremely helpful, high yield go-to guide. We'll take a few questions from the chat box. So the first question is, in case of level 2 positivity, when you said that level 7 has to be 7B has to be included when the upper level 2 node is positive. So how do you delineate that? How do you differentiate a lower and upper level 2? Is there a clear anatomic or radiologic limit to calling a positive node as upper level 2?
Yeah, so this is not clear, the upper and the lower, and also bulky and non-bulky. So there's no clear guideline mentioned in anywhere. So I'm not sure. I mean, unless you have very bulky disease, especially probably close to your first cervical or the second cervical vertebra, maybe it makes sense to delineate cranially. But there's no clear definition given anywhere, even for bulky as well as for cranial.
Okay, thank you. One of the candidate wants you to show the slides with the transverse cervical artery to show the delineation between 5B and 5C.
Yeah, sure. Yeah, I'm sorry, I had to took some time. I had to scroll through all the slides. Okay, so here I've come back to the arch of the aorta. So here you can see your three vessels. Here is the brachiocephalic trunk. The brachiocephalic trunk divides into the right common carotid and the right subclavian. So we know that transverse cervical is a branch of the subclavian. So we'll track the right subclavian over here in this case. So this here is the subclavian. So this over here, you can see this is the transverse cervical branch. This will go transversely into the neck. So this here is the transverse cervical artery. So as you can see here, it is going into the, so I'm going, please remember, I'm going from caudal to cranial. So I want to delineate, I want to include transverse cervical into my contour. So into my level 5 contour. So as we discussed, level 5 is lateral to the sternocleidomastoid. So this space over here. So as the transverse cervical, because I'm going from caudal to cranial, as I see the transverse cervical was vessels into this space over here, I will stop at this level. I will include level 5B till this level. So if I'm going continuing to scroll cranially, you will see transverse cervical vessel, all of the transverse cervical vessel will be cranial to this. So which means I'm including all these vessels. So this is your transverse cervical branch, which is cranial to the transverse cervical. So it's much more clearer on a coronal section. So over here you can see this is posterior to your sternocleidomastoid. This is your level 5 territory. Inside this, where the transverse cervical vessels enter, this is where you have to put your lower border to include your level 5B. So you have to include all this vessel inside your, so probably a good way is to always delineate the transverse cervical vessel so that you don't miss it. I hope it's clear.
I hope that solves the doubt of that candidate. So one of the candidate wants to see the levels in your CT scan in the area where the node was positive, when there was a gross node with ENE, I believe. So however delineated those levels, I don't think that side is delineated, is it? But then how would you delineate those levels? Whether you would allow your contours to go into the adjacent structures. I don't think a gross node delineation is part of this topic.
Yeah, we were discussing elective nodal delineation, but anyway, since it's a doubt, we'll clarify it. So in this case, so basically when you have a gross node, the common thing that you do is you contour the node and give a margin to it. So if it's a small node and if it's a node that you know doesn't have any perinodal extension, then usually for your high risk volume, your 5 mm is what most people follow, or even some people follow 1 centimeters. So you give a margin of 5 mm to 1 centimeter to the gross node, and restrict this to anatomy. So for example, if I have, I can say maybe this node, if it's small and I know it doesn't have perinodal extension, for example, so I give a margin, and if the margin goes into the sternocleidomastoid, since I know it's not invading the sternocleidomastoid, I will crop it off the sternocleidomastoid. But when I'm contouring this node here, which I know has obvious perinodal infiltration, it is going into the sternocleidomastoid. Then when I contour this node with perinodal extension, I'll give a margin of 1 to 2 centimeters, definitely more than 1 centimeter always. So give a margin of 1 centimeter and let it go into your normal structures which have been invaded. Like in this case, if I give a margin, you'll have a volume like this. So literally where it is going into the sternocleidomastoid, I'll let it go into the sternocleidomastoid, not crop it off the sternocleidomastoid. But medially with structures that are not involved, like the prevertebral muscles in this case, I will crop it off the prevertebral muscles. So since we were discussing elective nodal delineation, we did not discuss how to contour gross nodes, and I've not demonstrated it, but this is basically how it is done.
Thank you. So one more question, any tips for easier structure identification in post-dissection neck, especially in bilateral radical neck dissection?
Yeah, usually even if you have neck dissection done, I mean, if it's a modified radical neck dissection and if your sternocleidomastoid is retained, then usually you will not have issues even on a post dissection unless there is reconstruction. With reconstruction, you may have issues, but then again, you will have to, your anatomy knowledge is important over there. So if your anatomy knowledge is good, you will be able to still delineate structures. So again, like I said, you there, this basically this nodal delineation of cervical nodes revolves around 2 or 3 structures. So mainly the carotid, the jugular, and the sternocleidomastoid, and the paravertebral muscles. So if you can identify these properly and you've done enough cases, then it should not be an issue. Unless there is extensive reconstruction, it is usually possible to delineate.
Thank you. The next question is regarding level 4A and 4B of head and neck versus the SCF concept in breast cancer. So I don't know whether that is pertinent to the head and neck topic completely, but then how do you compare SCF in breast versus SCF in head and neck? Guidelines and delineation wise.
I didn't get the question. With breast, sorry?
Level 4A and 4B and head and neck, is it the same as SCF in breast? Level 4B of
breast. If you don't have a demarcation of 4A and 4B as such in breast, you call it supraclavicular. As per the RTOG guideline, they start at the caudal border of the cricoid cartilage, and your level 4A also starts at the caudal border of the cricoid cartilage. So yeah, delineation point of view, border point of view, they are at the same levels.